All right. We are live for our second to last live stream. And we're going to be talking about some juicy topics today. Some that a lot of people are not willing to talk about or don't really talk about openly, which is totally fine, totally understandable. We're just here to provide you with some information. So we are going to be talking a little bit about prolapse, pelvic organ prolapse, bladder health, and constipation. So pretty exciting stuff, and very relevant to many different age groups, because it is exempt from being at risk for things like that. So once we get Laura on here, here we go. Hello, Laura.
Hi there.
How's it going?
Oh, good.
Wonderful. All right. So I said we were going to be talking about prolapse. We're going to be talking about bladder health and constipation, and how this is super relevant for lots of different age ranges, not just women who are pregnant or postpartum, or even of childbearing age. This definitely affects lots of different ages, including from like adolescence up through postmenopause. So really all age ranges. And yes, does definitely affects men as well. So if there are men in your life, they also have pelvic floors and also may have these issues. So yeah, so I think would you want to get started? We'll talk, probably makes, I think, the most sense to talk about one at a time. So talking about prolapse and then bladder health and then constipation. And I'll try to keep us on track with timing. So we're doing like 15 minutes on each. So we make sure we don't skip anything.
Yeah, it's they sound like very different topics, but they are so interconnected.
Yeah.
And I love your point about, all the different age ranges. I would love to, like, my next venture is going to be to get this information out to like high school female athletes, because, prolapse doesn't necessarily mean that, you've had a disruption after a baby. It could be for any sort of repetitive downward pressure on our pelvic organs and our pelvic floor. So, high intensity sports does that. If we're holding our breath, if we're going into the bad postures, to achieve that high level task, if we're not doing it responsibly, we could be setting ourselves up for prolapse at a young age. And the same thing with constipation, or with even just like bladder habits. If you are constantly straining to have a bowel movement and pushing down on top of the organs, or pushing your pee out instead of letting it come out naturally, that's just that repetitive downward motion. So I think explaining a little bit about what prolapse is, we'll start off with, and then we can kind of talk about how we can manage it, either prevent it, number one, of course, but if we have some symptoms, how to identify them, and then how to manage them, because it happens. It's very common. Unfortunately, it's a very common thing. It's connective tissue. It's, it can get disrupted. But it doesn't mean that that's it for you. There's a lot of things that you can do to manage it and to live a very fulfilling lifestyle.
Yep.
And okay, here's my bladder. So I had a lot of people in my prolapse series, prolapse is one section of my pelvic health support series, and I used produce, I think orange, apple, and a banana for my pelvic organs, and people really liked it. My produce was not my fruit was not looking that great tonight, so I went with the same idea, but I used my actual pelvic organs in this little bag. Okay, so here's a pelvis. Okay, the pelvic bowl, this bony circular kind of shape, and then the pelvic floor muscles at the bottom capping it. Okay, so we have it's like a bowl, and the bowl is filled with pelvic organs. Okay, so here are the pelvic organs. Kind of hard to see, but here's your bladder. Here's your uterus, kind of behind and up a little bit, if you have one. And then here's your rectum in the back. So the pelvic organs we're like developed in this kind of midline orientation, okay? And then they sit in this pelvic bowl like that, okay? So the biggest thing that I like to point out is the pelvic floor muscles are underneath these organs, supporting them. They're not the actual structure that is suspending them and holding them up. The actual structure is this bag and these rubber bands that represents our connective tissue. Okay, so you have connective tissue surrounding these organs and attached to the inside of the bony pelvis. And then underneath that interconnected structure, we have the pelvic floor muscles joining in it and supporting. So when we get, whether it's childbirth or it's constipation or it's breath holding and straining during high intensity sports, the connective tissue can get disrupted. And then the organ, so if I'm going to take off some layers of rubber bands, which is our support, and then we can get a little bit of wiggle room and movement in here, okay? And when we get wiggle room, we can get shifting of the organs, okay? And so now we've got kind of a little bit of wiggle room. And then, you know, essentially, if we get enough disruption, these pelvic organs are going to end up kind of right on top of the pelvic floor muscles, okay? And imagine you've got these three organs, and then you have a vaginal canal. And these organs, if they get shifted, they can kind of push into that vaginal space, which is where we see the different types of, you can have the bladder pushing in and have a cystocele. You can have the rectum pushing forward and have a rectocele, or you can have the uterus kind of sliding down in the middle and having a uterine prolapse. And then there's all other different kinds that can really happen. You can have like the urethra, the tube of the urethra can actually slip down, or the anus can slip down. So you'd have different types of prolapses. The one that's very common that people identify, see, and have symptoms are the ones that are pushing it into that vaginal space.
Right.
And what you find is, you know, people get very, very apprehensive and they get very scared because they feel like, oh my God, I see my bladder. I can feel my bladder, right? And it's still produces a lot of anxiety, but the biggest thing is it is not your actual bladder that is out of your body. It is the bladder pushing into that vaginal wall that is now kind of pushing down into the opening.
Right.
Okay. So you see it kind of coming through this space.
Right.
So, regardless of why that's happening, you know, what you want to be thinking about is how can I support those structures and how can I stop pushing, like adding that downward pressure on it. People get, you know, slings, they get surgeries, they get lifts, but if they don't ever find out what they're doing to exacerbate that, it's not going to hold. You know, a lot of times people will have a surgery and then it gets undone. So making sure that, you can do therapy to be able to avoid surgery. You don't necessarily have to have it. It's not, unless there is some specific issue that's going on. There is nothing that's like if there's like some circulation or nervous system that's involved, but there's nothing with that, the organ shifting in place. It doesn't mean that that's necessarily a bad thing as long as you can manage your symptoms.
Right.
Yep. And then, you know, the other like big thing that I really like to talk about is the fact that, okay, we have this shifting and rearranging a little bit of our organs, and we're thinking about lifting. We want to lift them back up, right?
Right.
But the trouble is, if we start to do Kegels, which is like intuitively, that would be the number one go-to, is to start to squeeze and lift and drop things back up. But what happens is, because it's not really a weakness of the pelvic floor muscles. And I just want to make sure that people understand that. You know, I know like we put a lot on ourselves thinking, oh, I just didn't do enough exercises. I failed, you know, I wasn't strong enough. But it's that connective tissue. There's been a disruption to the connective tissue, and the pelvic floor muscles are responding to it. So a lot of times, you know, they know their job to help support. Now those organs are directly on the muscles, so they respond by working harder. So then you get into that overactive, hypertonic pelvic floor. And we know that a tight muscle is an ineffective muscle. Okay.
Yep.
It's going to be uncomfortable. Sometimes it's going to release and spasm because it doesn't have the ability to contract and move. It doesn't have the endurance. It's got nothing left to give because it's been kind of working on holding up the organs all day. So it can be very counterintuitive to think about lengthening your pelvic floor muscles when your situation is to want to lift things up, but really, you know, kind of coming to terms with that and getting a real good sense of your body awareness and being able to work through that. And it took me a while to be able to understand, like, why would I release muscles and try to stretch the tissue if it's a stretching that has happened? But the muscles need to be able, if they're overworked and tight, they need to be able to lengthen to be able to successfully contract. So that's the biggest thing, is just trying to figure out that where you stand in that whole relationship, and make sure that you're not just squeezing and doing Kegels that could be exacerbating that.
So if someone were to suspect that they might have a prolapse of some type, what kind of symptoms would they be experiencing?
Yep. So a lot of times people just feel it. So, you know, one big thing I always kind of try to instill in people is, if you don't have symptoms, start checking out your body. Start looking, start feeling, and getting a good understanding of what your baseline is, so that when you do have something that feels a little different, you can really actually know. Because sometimes we're like, oh, this feels different, but I don't know. I never really paid attention to it. So maybe it's not that different. So I would think, get to know your body so you really can identify these things better. But, you know, a lot of times people will say that they have like a heaviness feeling in their pelvic area, or their perineum, or their vagina. Sometimes they'll feel like there's a tampon in there, but there's not. So something like, if you've had a tampon in that's in the wrong way, you had that kind of weird offness. That's a common description. Or sometimes people can feel it, like if they're sitting on the toilet, so you're kind of in a little bit of a bent, a pressure loaded position, and people can feel that there's something that's just kind of coming out a little bit, or just a little bit like just inside, that normally they don't sense that. And then there can be different, you can have leakage, you could have urinary leakage, or you could have fecal incontinence, or you may be having some constipation, you may be having some pocketing. So like, if you imagine that the rectum has come into the vaginal space, you're kind of getting this little like loop that's happening. So sometimes it's harder to be able to evacuate and actually have a complete bowel movement. So you always have like a little bit there. So sometimes that's a good indicator that might be something going on.
And is it normal to have symptoms that kind of come and go, that aren't always necessarily there, that you're only maybe noticing like maybe in the evening, or when you're going to the bathroom, or when you're tired?
Yep. Yeah. It can definitely be situational, and it could be like a fatigue thing. So a lot of times at the end of the day, or if, you know, vacuuming seems to be a very common one, you know, that push and pull, and a lot of times and it's, you know, it's a little bit of an endurance sport. And like, so after doing a workout, or what's that?
Or shoveling the snow.
Yeah. So any sort of like prolonged task, you may feel more symptoms. Or just like at the end of the day, you know, you're thinking about like drops in your bucket. Like, how many drops in your bucket do you have before those tissues and gravity take on, and you start feeling more symptoms?
Yeah. I think prolapse is so interesting because I didn't know. So I had pelvic organ prolapse after I suspect probably was from my first birth, but I didn't notice symptoms until after my second. And when I went to initially see, because I knew, like I was teaching Pregnant Fit, I was doing what I do now. So I knew, I was like, I had the suspicion, but in order to, I kind of just like wanted to confirm my suspicion. So I went to who you'd think you'd go to. Like, I went to my OB's office, and, I can remember the only appointment they had available was with the nurse practitioner in the office. And I was like, that's fine. I just wanted to get in and figure it out. So I went in and I laid on my back and she checked and she was like, I don't really feel anything. And, you know, there's really no way of telling like definitively whether or not you have a prolapse. And I was like, that does not sound right. Like, how do you not know if my organs are like out of place? And I didn't even think, like, firstly, that she may not have been necessarily trained in that skill to check for prolapse, and also that gravity was a huge factor in the prolapse. So if someone suspects that she has a prolapse, who should she or he see?
Ooh, sorry.
Sorry?
I'm totally listening to you, but I had a really bright light. Okay, I'm back. Yeah, so I mean, your OB definitely can be a good first route. A pelvic health therapist can certainly help you. We can't diagnose, so you know, we're not. You know, the only way to know specifically what organ is behind that vaginal wall is to have an ultrasound. So even the doctors are, you know, are kind of like they're kind of using their best guess from, you know, if it's coming down from the anterior wall, like the front of the pelvis, it's going to be probably the bladder or the uterus, and they tend to have a pretty distinct look to them.
Right.
But again, you know, we're not actually seeing that organ, so we can't definitively say. Or it's coming, you know, something coming up from the bottom, it's going to be the rectum. But so, you know, to get an actual diagnosis and an actual grading, like a level. So there's 4 like levels of prolapse. You have to go to your OB. But then again, you also have to consider that, you know, you need to check in different positions, because gravity is a big factor in it. You know, the typical position to assess in is on your back. There's no gravity, and if you're only feeling those symptoms when you're standing, then you have to check in standing. So, you know, we've figured this out. We're assessing in different positions, and sitting and standing, on hands and knees, and the other thing is, so it's with downward pressure. So, you know, what we did before, commonly, is that we, you know, with one finger in and we're looking, have someone bear down. So they're applying that downward force. And what do we see? Do we see something coming down and towards us? And again, so that's only as good as the person can bear down. So they may not feel comfortable bearing down because they don't want to pee on you or they don't want to release gas. Or maybe they don't have the coordination to be able to bear down. Maybe they tense up when they think that they're bearing down. So again, you have to try to simulate the circumstances and really hear the client and what they're describing to be able to give them a full assessment. But regardless, you know, I think even if I don't see it or feel it, they have those symptoms. I'm going to train them like anything else. I'm going to make sure that their core is involved and engaged. I'm going to make sure their breathing is coordinated. I'm going to make sure that they're not holding their breath and bearing down. I'm going to try to make sure that their tasks are, you know, eliminating as much impact as they possibly can. So it'll all be kind of the same to be able to manage the symptoms.
As far as like treatment for prolapse, is it possible to ever be symptom free with prolapse, or is it basically like once you have prolapse, you basically just have to cope with the symptoms forever?
Nope, you definitely, there are a lot of things, you know, I kind of like rambled off a handful of them, but there's a lot of things that you can kind of throw at it to be able to manage the symptoms. And, you know, the goal, so sometimes surgery for some people is the answer. But I mean, I think certainly, you know, going through the paces to see if you can manage the symptoms before, and then if you kind of, you know, hit a plateau, then if surgery is something that you want to do and feels comfortable and right for you, then that's certainly a viable option. And then you've already got the groundwork and the foundational like building blocks to be able to keep that surgery and to keep it safe.
What about a pessary?
Pessaries, yeah. So there are a million kinds of pessaries. Pessary is basically like a brace. It's like a brace. So if you think of like, you had talked about foot orthotics before, or like we have abdominal supports and we have SI joint supports. So a pessary is a pelvic organ and pelvic floor support. So imagine there's a million different types. So they have circles, they have cubes, they have discs, they have all different kinds of shapes. And it's because everyone's so different, and it could be different structures that you're trying to support. But basically, if you imagine you put a tampon in, that's something taking up space in that vaginal space.
Mm-hmm.
And that can give you a little bit of support. So sometimes I'll even just have people, if they're only having leaking with running or with sports or whatever the activity is, sometimes they'll even report like, oh, but it's better when I have a tampon in. So that right there is a good indication that, a little bit of support may be just what they need.
Mm-hmm.
And so there's all these different types of pessaries, and you have to get fitted for it. And, the biggest piece of advice I give people is, if it didn't work, the first one didn't work, try 2, 3, 4 different kinds, because they're different sizes, they're different shapes, they're different styles. And, I've heard a lot of times like, oh yeah, I tried it and it fell out on the way to my car, and
Right.
that was it. So, being able to go back and kind of stick with it to see, because the pessary may be exactly, what you need just to get you through that one task. It can be something that people use all the time. So a lot of times pessaries were considered for elderly women. It gets put in by the doctor. It stays in for 30 days. They go back to the doctor. They wash it and they take it in and out for them. So it was a very like passive thing that was done to them. And it's very, very different now. So I've had people that just wear the pessary for sports, or they just wear it if they have a long day at work, if they're on their feet a lot. Or they wear it for, just during the day and then take it out at night or something, like there's all different options.
Mm-hmm.
But I've also had clients that have gone, you have to make sure that you can advocate for yourself, because I've had a client go to the doctor and they're like, oh, we'll just put this pessary in and you can come back and we'll take it out and wash it. And that was the plan at that doctor's office.
Mm-hmm.
And the woman was horrified because she still has a sex life. She's like, well, what, how is that going to help me? So, I mean, you can, as long as you are, cognitively aware and like dexterous, you can take them out yourselves. You don't have to have somebody else do it for you.
Yeah, that's definitely a consideration too. I mean, yeah, for sure. I never even thought of that. I didn't know that they left them in that long, to be honest with you. That's so interesting. Now, are women of a certain age, like depending on, like we said at the beginning, this prolapse is something that can affect people of any age. Are there better candidates for, therapy that will benefit more from therapy than other people? Like if people are older and maybe their connective tissue is not quite as strong, are they going to be more of a candidate for something like surgery or pessary versus therapy? Or do you think that therapy should always be the first port of call?
I'm a little biased, but I think especially, so if you're thinking about healing and you're thinking about support and strengthening, there are some people, especially if their connective tissue has, doesn't have the hormones and the hydration to be able to have that integrity anymore. It's not necessarily that we're going to, from therapy, rebuild that connective tissue, or maybe, but we can certainly support around it. And that's the ultimate goal, is to support around it and to start managing it. Especially like if somebody is older, they're having a harder time just standing up. So, breaking down like whatever task it is that they may be holding their breath and adding to that, or constipation. I mean, being able to manage that's going to just give you so much more longevity with your connective tissue, if you're not straining every day for long periods of time.
Yeah, absolutely. If someone suspects that they have prolapse, but may not necessarily be able to come to in-person therapy to see a PT or an OT, is it possible to assess for that remotely?
Yeah. So I love that question. So it's tricky, because being able to assess a prolapse is a challenging assessment for a therapist. We have to really be able to use our hands and be able to see and, you know, talk the client through being able to manage the pressure, to be able to apply it and see what's happening. However, I do think, you know, I do for like telehealth visits, I will talk someone through how to do a self-assessment for their pelvic floor, to be able to determine if they've got tight muscles or if they've got weak muscles. And so then we can really figure out which direction we should be going for treatment. So that being said, I haven't done it, but I totally could foresee trying to talk someone through feeling, because, you know, if they're already having that sensation of something's there, that heaviness feeling, you know, I would talk them through different positions and being able to feel and to be able to look. You know, they can use the mirror or they can use the screen. Like when we do telehealth, it's HIPAA protected, so it's a private channel, so it's not like that's going to get out anywhere. And they're not being recorded. There's some that do have that option, but there are very professional platforms that are for that specifically. So yeah, to be able to talk through that. And then, you know, the other thing is, again, like, you know, I'm not going to be able to necessarily tell you what stage it's at. I might be able to, but maybe not. But we can certainly work with managing the symptoms.
Right. Because it's sort of the same like pathway regardless.
Yeah. We're gonna assess where you may be breaking down and kind of build those pieces up.
Awesome. So let's use this as a little segue. We're going to go into and talk a little bit about bladder health. We did talk a little bit about this in previous weeks, specifically with like pelvic floor and exercise, you know, about like leaking and any kind of the certain kinds of continence, stress, and urge incontinence. So is there a general way that you sort of approach bladder health with your clients?
Yeah. So bladder health, there's kind of like two main camps. You have stress incontinence and you have urge incontinence. And then you can have mixed incontinence. So you can have a little bit of both. So stress is that there's a pressure and you're not being able to coordinate and manage that downward pressure and you get leakage.
So if you're jumping or coughing or sneezing or running.
Yep, absolutely. And then urge incontinence is more you get a strong urge and you have trouble coordinating the muscles to be able to hold them and get to where you need to go. And then mix is a little bit of both. It's very common to have a little bit of both. So that's kind of the incontinence piece. But there's also some bladder symptoms that you can be having from a tight pelvic floor or a weak pelvic floor. That don't involve leakage. So you've got leakage and you've got a couple different camps, and then you can have just urgency. You can just really strong urge, and you can have frequency, like you have to go to the bathroom all the time, but not necessarily because it's a full bladder. So or you could have increased frequency at night. It's called nocturia. So like having to go multiple times at night and disrupting your sleep can be very problematic. So
Absolutely.
yeah, what makes the whole urinary system so fascinating is that there's so many loops and connections. There's like all these inputs and outputs and communication going from the bladder to the pelvic floor that's underneath it. They communicate, and then from the bladder up to the lumbar spine, and then from the bladder up to the brainstem. So it makes it tricky. It makes it really interesting, but it makes it tricky sometimes to be able to tease out what's going on, because your brainstem takes in like information from your environment, from your different senses. So like, you know, it's very common. You hear running water, or you're washing the dishes, or you're brushing your teeth, or you get in the shower, or you get the key in the door. You just got home. You didn't have to pee 5 minutes ago at all, but now you're about to pee yourself because you can't get the key in the door the right way. So those are all kind of like urgency, kind of brainstem learned urges. The bladder's not necessarily full, because like a true urge is your bladder fills, and when it gets full, the lining stretches, and that creates an urge. sensation. And then the
Mhm.
pelvic floor muscles say, okay, I hear you. Let's calm down. The urge goes away, calms down, gives you time to get where you need to go. Healthy, functioning system. But because the brainstem likes to try to help us out and figure us out, if you get into the habit of going to the bathroom without that urge, you, like just in case peas, like I'm going to the store, I better go. I just went 10 minutes ago, but let's just make sure it's fully empty. Or I'm going to be doing this exercise routine, and there's all these like, or I'm going into a meeting and I better just go just in case.
Yeah.
So if you do that too often, your brainstem starts to say, all right, she likes to go when I'm only this full. So I'm going to send her that urge, and you get this overactive bladder cycle. And every time you go, it reinforces the brainstem's like, oh, she went. I must be right.
Yep.
So our bladder can learn our bad habits and start to get us into these cycles, but we can also retrain it. So the good news is we can reset it. You have to have a little bit of discipline. You have to like be aware of what you're doing during your day, how you're hydrating, and just kind of stick to your plan. Because every time you go, like especially at night, it's really hard because you just want to get back to sleep.
Mm-hmm.
But every time you give in to that fake urge, then it just reinforces it. So you have to, there's all different types of urge distraction techniques that you can implement to be able to get you through and reset it.
Oh, that's so interesting. So it's like you're training your brain, you're not just training your bladder.
Yes, absolutely. Yep.
So interesting. So now for people who do get up multiple times a night to pee, what's like the cause of that, and why, what can they do in order to like not wet the bed?
Okay. So, like a big thing that I start with is avoiding diary, to be able to figure out how are they hydrating throughout the day. Are they like drinking a gallon of water right before bed? Because then you're gonna have to get up. Like
Right.
you have to tease out, is it a true full bladder urge that you're receiving, or is it this kind of fake learned urge? So once you have the confidence to be able to know that, then you can really start to implement, because you don't want to be like counting backward from 100 by sevens just to like not go to the bathroom if it's a full bladder, right? You want to go.
Right.
And then so the voiding diary is the first step, just even throughout your day. But then like looking like, how is your hydration? Is it are you missing the morning and then like heavy loading in the afternoon and evening, and then you're just kind of flushing all that out at in the middle of the night. So usually a couple hours before bedtime, think about trying to taper down. I don't want anybody dehydrated, but starting to slow it down, and then making sure the one just in case pee I say is okay is well, no, there's a couple. Jump roping's fine. But is right before bed. So start to taper down a couple hours before bed, and then go to the bathroom right before you get into bed, and then you've got a good idea that you've emptied your bladder. You should be able to make it through the night, or at least just once. Sometimes once a night is the baseline for some people. But and then also looking at like any bladder irritants in the evening. So, trying to eliminate alcohol, caffeine, carbonation, those kinds of things in the evening time. And then putting into play the urge distraction techniques. So like getting your mind on something different. So even like listening to something sometimes, or like some breathing meditations can be really good. Using your pelvic floor to calm that system down, because when we have an urge and we start thinking about it and we get anxious about it, then everything tenses up, the pelvic floor tenses up, and that exacerbates the urge and makes it worse. So doing some pelvic floor lengthening breaths, trying to calm that down. Quick flicks is another really good technique. So like doing like little mini Kegels, like little pulses. So it's not a full contraction, because again, we don't want to be tensing up that situation. We want to calm it down, but like little mini pulses, 10, can be good to kind of like just calm the system down. If an analogy one of my mentors told me that stuck with me is that if you imagine you're in your car and you're sliding on ice and you slam on the brakes, you're going to slide across the ice. And that's like tensing up the pelvic floor is slamming on the brakes. But if you pump the brakes, then you can kind of ease your way across. So the quick fix is like pumping the brakes.
I like that.
Yeah. So, and then there's some other like mental distraction techniques too. So
yeah. So as far as like, what about people who have to feel like they have to like wear a pad all day long because they're like leaking? Do you think like what will work the best for them as far as trying to treat that stress incontinence?
So if it's stress incontinence, then trying to figure out, is it stress incontinence because the muscles are just low tone? And do we need to really kind of work on getting some coordination to do an effective Kegel? There's basically it's a Kegel. It's called the knack. And I think no other reason, just that it's a knack. It's like a learned technique. Being able to, like, if it's with coughing or sneezing, being able to do an effective Kegel and basically lift and support yourself so you can withstand that downward pressure. And then, looking at the breathing and the posture and all those things, making sure that you are able to support and withstand the downward or the upward pressure that's happening.
I think a lot of times, like culturally, I think age wise, I hear a lot of like older women who are probably, above 60 say like, oh, well, that just happens because, I had a baby. And some women don't even recognize it as an issue. And they just like every day they get up, they put a pad on, they go throughout their day, and they don't even think that it's a problem. And so, is bladder issues, stress and urge incontinence and whatever else there might be, are they treatable, say post-menopause?
Yeah. Yep. Absolutely. So this kind of field has been really up and coming the past, I'd say 20 years.
Mm-hmm.
So, before that, we didn't have an answer for people. And that was just kind of natural aging process, or what happens after you have a baby, because we just didn't have the knowledge and the research. Now we do. So, and it's, we had talked about this before, it's never too late. So, even if you've, it's been 20 years since you had your kid, you can still improve on these things and start to manage your symptoms.
That's awesome. I feel like that's great news, because I hear so many women that are just like, yeah, no, it's just something that like my doctor told me that I just have to deal with. And I was like, no, there are people. There's more people now for this than there's ever been. I mean, it's such a field, like you're saying. So now, okay, so we'll switch on to our last topic, which is constipation. So this is, again, one of those topics that can affect any age range, definitely from, adolescents and even like, toddlers, of course, when they're being potty trained, like my toddler, and then, up to, post-menopause. So like all age ranges can be absolutely affected by constipation. So how do you address it initially with each patient?
Yeah, just to build on your comments. So yeah, I mean, pediatrics, young children are having constipation problems, and there are things that can help them, that can greatly help them. They don't have to go through the suffering, the pain, and then have it turn into an adult problem. A lot of times, even with like bedwetting or any urinary problems with pediatrics, a lot of times it reverts back to constipation. So constipation is a big driver for other symptoms, pelvic floor dysfunction and urinary dysfunction. And I always like to highlight, so here's the bottom of our pelvis, our pelvic floor. So vaginal opening, the urethra, and the anus. So these are the pelvic floor muscles, cover both areas, bladder and bowel. Okay. And when you think about, a lot of times we think about our pelvic floor if it's failing us and we have incontinence, whether it's fecal incontinence or urinary incontinence. But, you know, constipation, you know, our muscles need to be able to coordinate to be able to maintain continence, but they also need to coordinate to eliminate. So we need to be able to effectively lengthen our pelvic floor muscles to have a bowel movement. So if, you know, there's a lot of different factors with constipation. So we want to be looking at hydration and nutrition and motility and what's going on in the abdominal wall. But also the pelvic floor muscles. So are they tight, and are they unable to lengthen and open? Or is it a coordination piece where when you think that you're pushing, are you contracting? Because our abdominal wall and our pelvic floor muscles, they co-contract, they work together. So if we're holding our breath and squeezing our abs, we're most likely closing and tensing and contracting our pelvic floor muscles too. So now we're trying to bear down with all our might on top of our pelvic organ, so that downward pressure through something that's tense and closed. So the biggest piece for constipation, well, one is to ask about it, because a lot of people will be like, no, I have a bowel movement once a day, I'm fine. But to dive deeper and say, well, what does it actually look like? I actually have, it's called the Bristol Stool Scale, and it's pictures of poop. And, you know, it goes from the top where it's like little tiny rabbit pellets, like the most constipated. And then it's like solid, but it's got bumps and cracks. Those are more constipated stools. Even if you're going once a day, if it's got those bumps and cracks, then that's a less hydrated stool, and there's some things that you can look at. And then, you know, the middle one is like a nice smooth, soft, sausage-like, I think it's described as. I know it's gross, but it happens. And that's the ideal one. And then from that middle level, it kind of works down to like more looser stools. So being able to really, you know, have an idea, and sometimes you swing back and forth, that happens often. But, you know, being able to really identify, you know, maybe constipation is something that someone's had all their life, so they don't associate it as something that they can help and improve on.
Right.
But, you know, working on the pelvic floor muscles, working on the motility, working on the posture and the breathing. So, you know, talking about, I think I called my constipation segment potty mechanics. So like, you know, learning how to set yourself up. A lot of people hear about the squatty potty now, which can be great. You have to keep, you know, be mindful of making sure it's the right height, because if it gets too high, then we start to kind of get into this like rounded crunched position. So you want to have a nice balance, but you want to have your knees above your hips slightly. You want your feet grounded. If you're up on your toes, because, you know, my instant thought when I heard, you know, about the knees above the hips, well, if I'm in a public restroom, I'm just going to go on my tippy toes. Well, if you go on your tippy toes, that engages the pelvic floor, and now you're not able to fully lengthen and relax at your best. So making sure your feet are wide and flat and grounded. Making sure your back is flat, because your back, your lumbar spine, your tailbone does what your lumbar spine does. So if you are rounded and kind of like a sack of potatoes on the toilet, your tailbone is going to be curved up and under and kind of blocking that pathway. If you have a nice flat back, it pulls that tailbone out of the way. So, you know, looking at the different posture pieces, because we want gravity assisted help. We want to make it as easy as possible. And then breathing strategies. So, you know, bearing down is putting the pelvic floor muscle, or putting the pelvic organs at risk. So working to coordinate the muscles to make sure that you're inhaling and opening and lengthening. And it can be very, very weird to inhale to have a poop.
Yeah. People tend to like hold their breath and bear down.
Yep. So just kind of, you know, playing around with that sensation of inhaling, lengthening, to see what happens, and finding that posture. And sometimes, you know, find the posture. If it doesn't quite work, maybe moving, like a little bit of movement back and forth, a little bit of pelvic tilts can help. And then And then the one breathing strategy I just want to go over quick. And if you don't get it, that's fine, because usually I spend a while explaining it, but it's called straw hand. And this can really, I mean, my son does it. He's 6. And he loves it. He's like, it works, mama. But so you find the posture, you practice the inhale and the lengthening and opening. Sometimes you need, if that doesn't do the trick and you need a little bit of more pressure to get things moving, then so I have you think about inhale and lengthen and open. So the pelvic floor is lengthening and opening, and the abdominal wall is expanding because it's that balloon, okay, motion. So you inhale and you expand, and then you hold that openness. So you've got the belly out, you've got the pelvic floor kind of lengthened and open. You hold that openness, and then you exhale into a straw hand. So it's basically just a closed fist. Okay, so usually when we exhale, the pelvic floor comes back up and the abdominal wall comes in. Okay, so like we're engaging our core, we do it on the exhale, that's when it's coming in. But for this specifically, we're going to open the space and we're going to hold that space. So when we exhale into the straw hand, you should feel, try it, you should feel like a downward opening in the pelvic floor space.
Oh, wow. That's so interesting.
Yeah.
And useful.
Yes. And so you can play around with different like sounds and vocalization. So it's basically a controlled exhale. I have found myself just skipping right to the straw hand because a lot of people don't like to moo or hiss in a public restroom. And the straw hand just seems to be a little bit more universal because they can be different. Like, you know, one person when they if they moo, they may feel the pelvic floor close, or you know, other people may feel open. So you have to play around with what does your pelvic floor do when you make different sounds. But typically like a deeper, lower sound will open the pelvic floor, and a higher, we had talked about this with the I forget what you called it, but that tongue to the roof of the mouth.
Yeah.
So yeah, so like a higher pitched sound can engage the pelvic floor. So thinking about straw hand or like a moo or a grr, something that makes you feel like that pelvic floor opens when you apply that pressure.
That's so interesting. I love that.
Yeah.
That's great. Awesome. And then as far as like, if someone was having a nutritional issue and like that was what was causing or like adding to their constipation issue, you know, do you have someone that you refer to for nutrition, or do you kind of give general guidance?
Yeah. So, I mean, I'm not a specialist and I'm not a nutritionist. I definitely because I'm still fairly new coming back to this area, I haven't gotten a great network of like nutritionists and diet. There's one in Hudson. I hope you don't mind me calling you out, but Jordan Schmidt is really great. She's, I think, busy, but if you look her up, she is wonderful and very holistic in her approach. And then there's some other people in the Berkshires that I found. So I am definitely always seeking. So if anybody hears this, contact me if you're a nutritionist or a functional medicine person. But you know, gut health is very interesting to me. That's another avenue that I want to, you know, dive, you know, headfirst into. But there's just so much out there. I know it's better to know what I can and then refer out. But there's so many like food sensitivities and like H. pylori and SIBO and IBS, and there's just so many things out there that all affect, you know, the pelvic floor and that connective tissue and digestion and, you know, movement in that whole abdominal pelvic canister. It's all interrelated. So being able to manage it dietary and hydration wise is a big component.
Yeah, absolutely. Absolutely. I think, you know, I mean, this is definitely like it's a wider discussion. But nutrition is just like so important when it comes to, action and not having like deficiencies that can cause you to become dehydrated quickly, like mineral deficiencies. Like there's a lot that you can address. And so kind of coming at it from more than one angle can be really helpful if you do have the time for it. And, I mean, we're in an age where everything is remote now. So we have tons of options. I had a client who actually, she drove down to Poughkeepsie to go to a holistic wellness center down there. And she was like willing to make that drive, but I'm positive that there are absolutely telehealth options, and they may include blood work. You may need to go do different things, but it's a case of like, what is most accessible to you? What makes the most sense for your life at this time? To address something like this. So to be able to like have a discussion with someone who sees it as like multifaceted, rather than I feel like a lot of times you go to their doctor and you tell your doctor your symptoms and they're like, it's fine. Like, it's not fine.
Yeah.
I'm here telling you if it was fine. So sometimes, but not, there are many doctors who are not like that. But being able to like have someone who's going to address it and say like, hey, you could go see this person, this person, this person. And it gives you like a really great leg up on, trying to address these issues, once and for all.
Yeah. And, like having that team approach, having a network and community of people to be able to help with that is so important.
Yeah, definitely. And we definitely, at Her Strength, we have had countless clients come in with all kinds of pelvic floor issues, including constipation and, bladder issues and prolapse. And we've been able to help them manage their symptoms. Sometimes by just like changing your position, changing your strategy. And again, like you're saying, changing your, your breath. That's really important. And so, to be able to, again, have someone who's going to coach you in movement, because if you feel better when you exercise, that's something that you don't want to, leave out of your life. It's important to talk to someone who gets it, who knows like, okay, where am I coming from? When I talk about these things, and do they know what prolapse is? And am I comfortable talking to them about, my bladder health? So
Yeah. And that's, your gym is just so like responsible. Like I know I can send people there and they're going to get good, responsible information and support. Because there's not so great stuff out there. There's a lot of like fear provoking ads out there saying like, oh, pull that diastasis back in and, get this 6-pack or this is going to happen if you don't fix this. And, really kind of getting away from that fear-based marketing and really just, supporting the clients and building a community for them.
Yeah, absolutely. I mean, we just want, I think you and I are on the same page when we say that, we definitely want people to just live their lives in a way that is more conducive to them enjoying it on a regular basis and in every aspect, not just in our respective fields, but like overall quality of life is so important. And so to be able to address those kind of things is great, which leads me into our next week, which will be our final live stream before we can definitely come back to this for sure. But next week we'll be talking about sexual health as it relates to the pelvic floor. So definitely not one to be missed. We will be ending this off with a very interesting topic. And if you do have questions relating to sexual health and pelvic floor, obviously everything remains totally anonymous. Please send us a message, myself or Laura, and then we'll definitely work it into our stream.
Yep. Are we going to talk about like menopause questions and stuff like that? Hormones?
Sure.
Okay. Yeah.
It's going to be all you.
Toss it in there. Yeah, we're just going to toss it all. Grand finale.
You can answer them. Awesome. All right. Well, thank you, Laura. Yeah. So another fun live stream. And we will be live next week on Monday at 7:00. Providing I don't have this baby by then, it'll be fine. I won't. Keep my legs closed. Haha. Otherwise, we'll see you all then.
All right. Have a great night.
You too. Bye.